So when we look at shock, we remember that this is a life-threatening condition, so we have to treat it. Treatment is the same for all of our types of shock, right? We're going to give them oxygen, we're going to keep them warm, and we're going to take them to the appropriate facility. So if it's a trauma patient, it may be a trauma facility. If it's a medical patient that's going to cardiogenic shock or a hypovolemic shock due to flu, vomiting, diarrhea, you're taking them to the appropriate facility, and we need to be able to recognize this in the field so that we can now pass that on when we do our handoff report, that patient advocacy, right? Making sure that this patient doesn't end up in the hallway, that they're recognizing that this patient now is progressing, okay? So when we look at shock, right, and our medical name for shock, hypoperfusion, literally means low perfusion. So our perfusion, delivery of oxygen and nutrients, our glucose and water, right, to all of the cells, and those removal of waste products. So aerobic metabolism, removal of CO2, a little bit of heat, a little bit of water, those are the waste products, right? So we need to make sure that those are constantly being monitored and that the body's able to meet those demands. So when we look at our types of shock, so we have our types. So the first one we talk about is our hypovolemic. Okay? So hypovolemic, low volume. So now when we're looking at this can be caused by internal, external bleeding, vomiting or diarrhea. So this is the type of shock that we see very frequently in our line in EMS, right? So we have lots of patients, trauma that have internal, external bleeding. We see patients all the time that are sick that are dehydrated, vomiting, diarrhea. So this is something that we frequent. So this is one of our types of shock, one of the most common that we see, and probably the one that we're most familiar with identifying. Then we have our cardiogenic shock. All right. So when we look at cardiogenic, there's a pump problem. The problem is with the heart. So for our EMS levels here, we're really focusing on looking at our MIs and our congestive heart failure. Right? So in both of these cases, we know if a patient's having an MI, we know if they have a history of congestive heart failure, we know now that they have a damaged pump, right? That's going to contribute to this type of shock. So cardiogenic shock, the problem with the perfusion is due to the pump. Heart's not working properly. Then we have our next classification, and that's going to be obstructive, and we're going to see that we have those three things that fall under obstructive shock. So we have obstructive. Okay? Now under obstructive, when we look at this, we're talking about obstructive being something that's interfering with the lungs and or heart being able to work properly, right? So we look at our tension pneumothorax. All right? So this one we've talked about, and we've looked at, this is where now we end up with, we have, a lung that's damaged. So this could be by external trauma. Maybe we have damage to the thoracic cavity. So, a knife wound, bullet wound, gunshot wound, something that's now caused damage to the integrity of the thorax, right, the chest cavity. It could be internal. It could be now that we had a patient with COPD, they had a bleb, a weakened area of the lung that now kind of let go, causing them to end up with like a simple pneumo, right? So a simple pneumo, we have that one lung that's now collapsed. What happens over time is as that air is now filling up the cavity, so it's not going into the lung, it's now filling up the space where the lung sits. It starts to fill up that thoracic cavity, and as this air settles in there, it's not able to escape. So now it puts pressure on the heart and the other lung, and it starts to smush them over to the side. Really late signs, this is where now we're looking for that JVD and tracheal deviation. Remember the tracheal deviation, we're going to see that shift towards the unaffected lung. So if my right lung collapses, as that pressure starts to push everything towards the good lung, I'm going to start to see very, very late signs, that tracheal deviation. Okay? In this field, generally when we see this is, a lot of times the patient is already deceased. Very late sign. So in your trauma assessment, we're always, I'm checking for JVD and tracheal deviation. We just want to recognize those late signs. Early signs we're going to recognize for tension pneumothorax is going to be poor bag compliance. Right? So we go to squeeze the bag, and all of a sudden it's hard for us to be able to get air in. If we have an open sucking wound, gloved hand, occlusive dressing, right, to prevent air from going into the cavity. But we also know that if we have somebody with a simple pneumo and we're ventilating them over time, we're probably going to cause this. So we want to make sure that our airway, we're on target, making sure that we're watching this and we're watching for the development of this tension pneumo. Tension pneumo, life-threatening. Okay? So that's one of our types of obstruction. The other one is our cardiac tamponade. Right, so when we look at our cardiac tamponade, we have a heart, the myocardium, the muscle. It's protected by the pericardium, that fibrous sac. So what happens here is, again, potentially a trauma, usually blunt force, that causes cardiac contusion. And now we start to have bleeding in that pericardial sac. Right? So now what happens is the space between the heart muscle and the pericardium is filling up with blood. So what it does is it prevents the heart from being able to beat. So you kind of look at your hand, and you open and close a fist as your heart beating. If you take your other hand and you squeeze, you can't open and close that hand. That's what's happening with that pressure that's now being exerted on the heart. The heart's unable to do the job of contracting and relaxing. So now we have this cardiac tamponade. Because this is generally a closed injury, we're not able to see cardiac tamponade. I can't see the pericardial sac filling with fluid. Right? If we have a patient, we can see that, and we know they're in a bad way. This is where now we're looking for that triad. So we have that Beck's triad. So for our cardiac tamponade, Beck's triad. So we have JVD, that jugular vein distension, due to blood backing up because of the pressure on the heart. We start to have muffled heart sounds. So we start to listen with our stethoscope, and we start to hear that the heart's starting to sound muffled because it's not able to beat freely. And then we have the narrowing pulse points. So a lot of times this is going to result in hypotension. So this is now our systolic and our diastolic, our blood pressure. We start seeing those numbers come closer together. So if I start with something like 140 over 70, and my next blood pressure is 120 over 80, we're seeing that these numbers are getting closer together. So when we take our vital signs, we're checking that trending, we start to see this narrowing, okay? These three things, we have three symptoms. When we have all three of those, we meet the criteria for Beck's triad, and that tells us that potentially we have this cardiac tamponade. We have a high index of suspicion for that, okay? The third thing for obstructive, this becomes our pulmonary embolism. Okay? So this is now that pulmonary embolism. That's where we now have that blockage in the vasculature of the lung. So now the lung tissue, the parenchyma, it's not able to get its oxygen supply. So now we start to have lung tissue that starts to die. So this pulmonary embolism, again, when we start looking at how would we recognize this, we're kind of looking at that patient history again, right? So this is an acute shortness of breath. There's no history of them being sick or fever. They have kind of chest pain upon inhalation, and we start to see now we're looking at maybe they were on a long distance flight, or they were in the car for a long period of time. They've been sedentary for long periods. So now what happens is they get that DVT, deep vein thrombosis, and when that breaks off, when they start to move around again, that clot releases, and the emboli, remember that thrombus, so deep vein thrombus, it forms in those veins, and now it shoots off and it lands in the lung, and we have our pulmonary embolism. So post-surgery, we're concerned about this, if they have a broken bone. These are all things now in the patient history. If we show up and they've got shortness of breath, I'm now concerned about a pulmonary embolism. They're going to have to go to the hospital and get a chest x-ray, get a blood work, have something called like a D-dimer to confirm that they have this, so we can't diagnose this in the field, but we're looking at, again, that index of suspicion, we're concerned. So these are three of our types of shock. Then what we have is distributive. All right? So now under distributive, when we talk about distributive, we're talking about systemic. These are things that are going to affect multiple body systems, right? So we have our anaphylaxis. So we should be well versed in this. So anaphylaxis, this is, again, is caused by that histamine release. We have, this reaction and oversensitization to some type of allergen. So an allergen, unlike a poison, in and of itself, a strawberry isn't poisonous. Most people eat them and enjoy them. They're great with, like strawberry shortcake, lots of whipped cream, ice cream, chocolate sauce, all that good stuff, right? Somebody who has an allergy to strawberries, now when they have an anaphylactic reaction, they have that airway involvement. So we have this histamine release, we have this overproduction, and now the histamine causes vasodilation. It causes the vasculature to become permeable, so the plasma starts to leak out. We can start to get that edema, we start to see urticaria. That's that pocket of swelling. And when they get it in the upper airway, this is where now we have that stridor. So now we start to have that stridor, we can have wheezes in the lungs, we start to have this overrun of the immune system, the inflammatory system, and this is life-threatening. So this, we would intervene with our EpiPen, our epinephrine, right? So our adult, 0.3 milligrams we would administer, 0.15 milligrams for our pediatrics. And this is something that we would need to recognize immediately is life-threatening. So we have our anaphylaxis, anaphylactic shock. We have sepsis. So we've talked about this. This is a bacterial infection of the blood. Right? So when we look at this infection, what happens is, at rest, this is where now, on average, resting adult, our blood circulates about 3 times a minute. So it's now come in contact with, every part of our body, all of our organs, at least 3 times in a minute. We introduce infection, and that's why we spend so much time talking about preventing infection. Because all of a sudden this comes, we introduce infection to our patient. Sepsis is one of the #1 things that kills patients in the hospital, right? So now they have the infection and they have it everywhere. So none of the body systems are able to help out any other systems because they're all trying to fight for themselves. So the body becomes overwhelmed. Same thing here, sepsis, we have this bacterial infection, we have that histamine response, vasodilation. We start to have that permeability. They lose a lot of volume, so we also see them become hypovolemic. So with a lot of our shocks, we can have multiple types, especially as the body starts to, start to fail. And so sepsis here, what they need is an antibiotic. So we need to get them to the hospital. They need to recognize and get them on an antibiotic. So again, we want to be able to recognize these patients early to make sure they're identified in the emergency room so they can start treatment immediately. Our third type of distributive shock is going to be neurogenic. So neurogenic shock, this is going to be a spinal cord injury. Okay? So we remember we have the brain, we have the brain stem, and then we have the spinal cord that follows. All of our autonomic features, our parasympathetic nervous system, our rest and digest, our feed and breathe, those, heart rate, breathing, blood pressure, all of those are controlled higher up in the brain stem and in the spinal cord, all right? So depending where, this is somebody's brain, and then we have our spinal cord, not drawn to scale, depending where we have the severing of the spinal cord, we have this injury. Everything from the injury down is potentially where now we can see paralysis, and we can start to see, kind of these injury patterns. So if this happens and it disables the sympathetic nervous system, remember the sympathetic nervous system, fight or flight. So if it disables that, now the body isn't able to have that catecholamine release. We can't have epinephrine and norepinephrine and dopamine and cortisol, all of these things that now get us ready to fight or run away. I always choose run away, right? Now, if we don't have those things, the only thing left is that rest. So now we have that vasodilation. We start to see the patient, become bradycardic. So this now, again, this is a very late sign. We generally don't see this in the field, but you may be going in and now after a patient's had an injury and potentially surgery and we're taking them to kind of a long-term rehabilitation, you may now see these signs of neurogenic shock, okay? When we look at these types of shock, these we recognize because our patients become pale, cool, right, diaphoretic, sweaty, because we have that sympathetic response. We have that catecholamine release, we have vasoconstriction, so the vasculature gets deeper into the body, they start to look pale, they start to feel cool to the touch. We recognize a patient who's pale, cool, diaphoretic. This patient, we already know by looking at them and their skin vitals that they're in shock. We're gonna start treating aggressively, okay? When we look at our distributive shock, this is where now the patient looks red or flushed, because they have that vasodilation. The vasculature is closer to the surface of the skin and gives them that flushed appearance. They start to feel warm, and a lot of times they're dry. So even though the kind of initial assessment, a lot of times people will kind of miss this and be like, oh, well, they look flushed, so they must be healthy. That's not the case, all right? Remember sepsis, infection, so we want to make sure that we're treating for these things. So these are our types of shock. Our treatment, no matter what type of shock, is the same. Oxygen, keep them warm, right? Because they're not going to be able to thermoregulate. We need to do that for them, and then get them to the appropriate facility so they can start their long-term treatment to be able to reverse this, okay? So here's our types.